You're a son of elderly parents who need your care. You're a husband to a beautiful wife. You're a father to 5 wonderful children. You live in the most remote part of Western Nepal. For a living, you own a family farm. You generate approximately $141 per year. You recognize that $141 is not enough to sustain the life that you would like to give your family. So in order to generate additional income, you sacrifice your personal life to move to northern India for months at a time to generate additional income. Your family's left behind to care for the farm, specifically your wife managing all of the daily responsibilities. Your daughter, she has a great entrepreneurial spirit. She wants to help out any way she can. So she determines that she can make additional income by collecting mangoes from the mango tree and selling them at a local tea shop for additional money. Unfortunately, one day while collecting mangoes from the tree, she falls. She fell unconscious on the ground and sat there for hours until a local passerby and a goat herder found her. They picked her up and carried her to the local hospital. The walk was approximately 3 to 4 hours in the heat over rough terrain. The hospital they arrived at is called the Bayalpata Hospital in the Acham district of Western Nepal. Immediately, she's seen by doctors and nurses in the emergency room. They assess her condition. They determine through a series of x-rays that she has a collapsed lung and a broken leg. With a collapsed lung, the doctors needed a chest tube to simply remove the fluid surrounding her lungs so that she could resume normal breathing activity. The problem, we were in a hospital in the most remote part of Western Nepal. We couldn't find the chest tube. There were doctors, nurses, maintenance staff, office workers running around with their heads chopped off trying to find a chest tube when some of them didn't even know what a chest tube was. It was at this point I was working at the hospital for about 2 weeks. I recall with my colleagues being in the warehouse and seeing something that may have been what a chest tube was. We went down to the storeroom, we located a few different items. One of them was the chest tube. We successfully were able to give what the doctor needed. He was able to help the patient, but due to so much trauma, she was unable to survive the night. It was at this point in time that I realized the impact that I could have as a supply chain professional on a hospital in the most remote part of Nepal. Good afternoon, everyone. My name is Bryan Baylis. I have about 16 years experience in the pharmaceutical industry, from research and manufacturing to procurement to project management to supply chain. My goal here today is to share with you a pretty neat experience that I had, one that was certainly life-changing, and to hopefully inspire some folks in this room about how we as supply chain professionals have skills that can really benefit people that are in need. So as I mentioned, I work for Merck, which is a large pharmaceutical company. We have approximately 55,000 employees globally. And every year, Merck has our philanthropic organization. We have a foundation. It's called the Richard T. Clark Fellowship, named after a former CEO. It's a global program designed to leverage the skills and talents of Merck employees to help build and support the efforts of humanitarian organizations to address the health needs of the underserved. So each year, Merck identifies and sends approximately 15 to 20 employees. They take their skills and match them up with skills that a nonprofit could utilize. We take a sabbatical from our job for approximately 3 to 5 months and completely immerse ourselves with that nonprofit, utilizing our skills to help them. My assignment was the Bayalpata Hospital in Nepal. The objective, to improve the quality of available health care in Western Nepal. And when I accepted the offer, they said, your job is to install durable supply chains for life-saving medicines and surgical supplies within the hospital. That was simply the direction that I was given. The team, so I can't forget, there were 3 of us from Merck that were chosen to go on this assignment. The first guy, Philip, myself, and Nardi. Philip and I are based in the United States, in New York City, and Nardi's from the Netherlands. The 3 of us, we were chosen to go on this assignment. The first guy, Philip, myself, and Nardi. Philip and I are based in the United States, in New York City, and Nardi's from the Netherlands. The Immediately, we work at a company of 55,000 employees. Surprisingly, we're all in supply chain management within Merck. The three of us had never met before, and we were all working within Merck between 10 to 12 years. Immediately, we met and we had to bond. We knew that we were on this critical mission to help this hospital. We immediately called ourselves the Three Amigos, and from there, the story begins. So a little bit about the hospital. The hospital was founded in 2005 by two doctors from Harvard. It's a private-public partnership. So Possible is the NGO located in Manhattan, New York City. And they work along within the Poly government. So they both provide funding, medical supplies, and whatever's necessary to run the hospital. The hospital provides 100% free healthcare to all patients. They're a local advocate for the community. So not only do they treat patients, but they work as a community advocate to teach the community about domestic violence, that there are resources to help women that need help. Maternal health. Approximately 1 out of every 125 women while giving birth die. Before this hospital was founded, there was not one single allopathic doctor within this entire district. So the challenges, being a Westerner coming from a very developed country, we left our comforts of our corporate environment for the comforts of Nepal. And if we were lucky enough to have the hospital ambulance, this is how we would drive to the local town called Sanfei Bagar. Otherwise, it was a 45-minute walk downhill and then maybe a 2.5-hour walk back uphill after you got done eating. The location. For me at the time, I was living in Philadelphia. We traveled to Doha, Qatar, 14-hour flight. From Qatar to Nepal, another 5 hours. Kathmandu to Dungadi, which is a small city about 1.5 hours west via a domestic flight. The day we arrived in Dungadi, it was about 110 degrees. There's no air conditioning. It was quite the shock for us. From Dungadi to Acham, it's an 11-hour Jeep ride. Through switchback mountains, the absolutely most gorgeous drive I've ever had in my life. The views were, as you can see in this picture, amazing, but also the most nauseating. When I say roads, they weren't really paved roads. It was, rocks. We were going approximately 5, 7, 10 miles an hour to get to the hospital. Water. Approximately 75% of the residents in this district do not have clean water. The hospital did not have running water. We had large holding tanks that every day needed to be manually filled up, and then we would siphon the water into the hospital. Electricity. Approximately 95% of the residents in this district do not have electricity. So here's a picture of us at night eating dinner on a Friday night. We would take a flashlight underneath an old plastic Rubbermaid table so we could illuminate and see each other as we enjoyed our meal. The food. The main staple is called dal bhat. So 3 times a day you eat white rice. It's called a roti, which is a sort of like a tortilla shell, and then lentil soup. We were in a very impoverished area. Approximately 11% of children under 5 have acute malnutrition. The lentil soup was really, I called it lentil juice. It was water with maybe a few crushed up lentils in it. We all lost weight while we were there. I lost about 25 to 30 pounds over the course of 3 months. The challenges. So anybody that's ever worked in the healthcare industry, in a hospital, have interacted with doctors or nurses, their specialty is caring for the patient. That's what they're trained for. So their priorities focused on short-term treatment of patients. And that was first and foremost what they did. There were everyday patients lined up when the hospital would open at 9 a.m. They needed to treat those patients. Lower priority was long-term procurement, supply chain, and general management of the hospital. So, when you travel to an area like this that's extremely impoverished, you have your perception of what it's going to be like. And being in New York and Pennsylvania, in my mind I thought that this was going to be a very impoverished area, which it was, but just that this is going to be a very unique experience and much different than life in the US, and it was. But over time, you're working in the hospital, and the 3 of us lived on campus. We had a dorm room on the hospital campus. And you see, every day you wake up in the morning and you see approximately 300 patients, or 200 to 300 patients waiting to get treatment. They've walked anywhere from 2 hours to 3 or 4 days to get to the hospital. So when you're there, you realize that this hospital isn't necessarily changing the culture of Nepal, but they're filling a basic human need. Maternal and child health. As I mentioned, maternal health is a major issue and something that they were concentrating on. Communicable disease treatment. So the highest rate of patients infected with HIV are located in the Acham district where this hospital was. Emergency for trauma. Every day that I was there was a kid that got hit by a car, somebody coming in with a broken knee or arm. An active community health program. So the hospital operates as a hub and spoke model. So the hospital is the main hub for treatment and care, and then you have the spokes. You have folks that are volunteers in the community that have health posts that help that local community surrounding the hospital. Maybe it's a day walk from the hospital. They help that local community educate them on healthy eating habits, on when you're cooking, open the windows so the smoke from your fire, you're not inhaling that. So the active community health program is very important and vital, and the idea is to prevent patients from even having to get to the hospital. And again, as I mentioned, approximately 300 patients per day. It's interesting. I mean, it's life-changing when you're in there and you see the patients that really need care. They're waiting to come into the hospital when the hospital doors open. So what we did, the three of us split up the supply chain. When we arrived in Kathmandu, the main city, the three of us looked at each other. We met each other for the first time, and we said, "What the heck are we doing here? We're not nurses. We're not doctors. We're sort of old supply chain fogies, and what kind of value are we going to add to this hospital?" And we were very not optimistic about what we were able to accomplish. We split up the supply chain into the external piece, so everything from how are we procuring our drugs, where are they coming from, are they legitimate drugs? There's a lot of issues with counterfeit medications when you get into the third world countries. Then the second half was the internal supply chain. So once those drugs arrive in the hospital, how are they organized? How do we know when to reorder new product? How do we know when to pay our bills? So we diced it up that way. So externally, our accomplishments. We started out, and it was really interesting, we actually physically walked the supply chain. So we started in Kathmandu. Before we even arrived at Kathmandu, we had teleconferences with some of the staff. We said, okay, we want to understand what the baseline is here. What do we have to deal with, and then what do we have to change and build upon? We quickly realized our first teleconference, the doctors and the hospital director did not know where their product was coming from. They sent us to one city. The next week we got emails saying, oh no, our product comes from these cities. We quickly realized, all right, there's some value maybe in us coming here. So what we did was we benchmarked supply procurement practices at peer hospitals. We looked at the top 3 or 4 hospitals in the city of Kathmandu, the best hospitals, to baseline, to understand, life is different here than what we're used to. What can we expect out of our hospital in Western Nepal based off of what these top hospitals are doing in Kathmandu? We met with government representatives to document the supply flows of HIV and tuberculosis medications. So we were informed that because it's a private-public partnership, that the local Nepali government is sending HIV and tuberculosis medications directly to the hospital. Again, we realized in our first phone conversation, well, that's supposed to happen, but it hasn't happened yet, and we've been waiting for 3 years for this material to get to us. We learned the Nepali private supply systems and documented current private supply chains. So you have your manufacturer. All of our manufacturers were really based in Nepal. We have the super stockist, the stockist, and then finally gets to the hospital. One of the lessons learned here, initially when we were, again, brainstorming in Kathmandu, we were doing our benchmarking with the top hospitals. The 3 of us got together, and every night we would sort of brainstorm, okay, this is what we did today, let's make a list of what we need to do tomorrow. And you have this impression, well, in the United States, if drugs cost a lot of money, if something costs a lot of money, let's get out the middleman. We're in this country, why don't we go to the manufacturer and say, let's get rid of the super stockist, the stockist, and go right from the manufacturer to the hospital, bam, we're gonna save a ton of money. Everybody's gonna be thrilled that we did a great job, we're gonna be rock stars. As we traveled through the supply chain physically, so we went to the manufacturers, we went to the stockists, we recognized that those stockists and the super stockists, those middlemen, when you're in an area like this, they are your advertising and your marketing guys. The drug companies rely on them to get the product to the hospital. So there really was not a way around that. So it's a way that you need to stop thinking ahead and really take a big picture, look at it, and sort of determine where you can go from there. So that was a big lesson learned that we, thankfully learned very early on in the process. We also detailed a comprehensive procurement strategy, which included controls to safeguard quality and costs. So again, due diligence is, the three of us were all within we all had spent some time in manufacturing drug product. So the first thing we want to do is let's nip this in the bud. How many of these drug manufacturers are legitimate, providing good quality product to our hospital? Because that was a really big concern that we had. Surprisingly, and I'm happy to report that all 4 or 5 drug manufacturers that we went to, they had quality controls in place. They had standard operating procedures in place. There were fine-tuning that we were able to do, and it was interesting. We show up, and you're in an environment that's totally new. Will the local folks, will the culture, will these drug manufacturers accept us to come in and really do an audit of them? Or in the U.S. that would never happen. They welcomed us in. They wanted us to help them get to the next level. So we would do a due diligence, and at the end of the day have a breakout session to say, hey, these are things that you're doing great. Here's what you can work on. But at the end of the day, we were able to now go back to the hospital saying, hey guys, all the product you're receiving, we know that the API, your active ingredient, is coming from reputable manufacturers in India. It's not coming from maybe a non-reputable manufacturer in China. Identified drivers of medicine spend. So, you're looking at making the hospital more efficient. Okay, we know where we're getting the drug product from. We have no idea what the hospital is ordering, how much they're ordering. How do we create an efficiency here? So, once we arrived at the hospital, it was a matter of putting together a simple Pareto chart, something that we would probably all do with our eyes closed with an Excel sheet. Gathering the data to put into this sheet took hours and days. We were going through manual papers. We put this list together, and we met with the hospital staff. And we looked at the top spend was omeprazole, which is used for acute, people are coughing. And what we realized, the hospital director came to us and he said, well, I know a place we can get this medicine cheaper and better quality than what we're currently getting. The next item, or a couple items down on the list, was vitamin B. And one of the doctors said, vitamin B. He said, why do we have such a high volume? Why are we prescribing so much vitamin B? And when you got the entire hospital staff in a room, we came to the conclusion that if a patient came to the hospital, they had a cold, the doctor's not going to prescribe them an antibiotic. They don't need that. They would give them vitamin B because if that patient goes to the pharmacy in the hospital and does not get any pharmaceutical drug, and they walk 1 to 2 days to get home, in their mind, they're thinking, well, I'm never going to get better. So it's almost a placebo effect. So by putting this together, again, gave visibility to the hospital with how they're operating. They had no idea. From here, this is a starting point to say, okay, what are the next steps? Let's trickle down and go down each bar here and see what we can do to create more efficiencies and save money. So again, with that Pareto chart, we went back to all of our manufacturers and received quotes. We looked at getting tiered pricing for a lot of our drugs, grouped them together through different manufacturers. And from there, along with the staff at the hospital, we were able to make informed decisions, smart decisions on where we should go and how much we should pay. Moving into the internal supply chain, we had, it's a small hospital, but it was pretty, once we arrived at the hospital, it was pretty complicated. It was not something as simple as all the medicine shows up and the doctors use it. We had incoming goods. Incoming goods, again, you had that 11-hour Jeep ride from the nearest city. The product is placed on the local public bus for longer than 11 hours because the bus is not as quick as our Jeep that we had to the hospital. So you're maybe looking at an entire 24-hour period by the time the bus gets to the hospital. The bus stops up front of the hospital whenever they get there, and they push the drug off the top of the bus and it falls on the dirt road, and it sits there until somebody from the hospital recognizes they have a package. From there, the product is placed in the medical and then the storeroom, and then again, distribution to customers. So our internal customers were our emergency room, outpatient facility, inpatient, the operating theater, health posts, and then the police and external facilities. So our major area of focus was really end-to-end flow, right? Looking from the time that bus shows up until the time the patient picks up the product from the pharmacy. Physical upgrades. We'll get to it in a future slide, but physically, their level of cleanliness is not the same as we would have in the United States. So there were some physical upgrades we needed to do. One of the big key components of this project was an inventory IT system, a selection and implementation, a big critical piece to make sure that we could really have a sustainable process for the hospital to use. And then finally, standard operating procedures. So the internal supply chain, the initial state was multiple dysfunction. Again, supplies were dropped off by the public bus, unprotected from the elements. Here you can see a picture of the storeroom the day we arrived. There was a nice couch for sleeping. There was zero organization. The storeroom manager, T. Lockman, was a wonderful guy. Was always running around, didn't know what he was doing, very confused because he was always being drawn to different places. When we talked to him and we said, T. Lockman, how do you know when to order omeprazole or vitamin B? And he pointed to his head. He had broken English. He pointed to his head. He said, it's up here. And when you're running a hospital of 300 patients a day, that's not good enough. So internally, we had physical upgrades of the storeroom, and each room one by one we tackled. So what you can see here is really, let me back up a second. Take yourself out of this room and place yourself in an environment where you have no running water. You have electricity, but it's not guaranteed. It's hot, you're stressed out. You don't have a Home Depot or a Staples or a hardware store like you do in the US or maybe here in South Africa. How do you accomplish building a shelf? Something as simple as, this is Christian on the right-hand side. We actually had to walk to the local village, a 45-minute walk downhill, and work with different carpenters. I would draw up plans. Okay, this is what we would like to do. We would go to multiple carpenters, get quotes. Krista was sort of my translator because nobody really spoke English in the small town. And Krishna said, we can't go to this guy because we used him before, we paid him, and he never gave us our product. So something as simple as building a shelf turned into me mentoring the hospital staff and Krishna specifically. Okay, well, we have to put a contract together. Very simple. We need the shelving by this date, this quality, it needs to look like this, sign off on the drawings, and if we don't have it by this date, we're going to deduct X percentage every week or every day that product is not delivered to our hospital. Formulary development. So we had, again, when you're looking at consistency throughout the hospital, when we put that Pareto chart together, what made it difficult was everybody called something different. So here's an example where we had the old name was Mersilk 2-piece per unit. Well, what the heck is that? They were sutures. So really, and my colleague Philip, he concentrated on formulary development, making sure we had the right name and a code for every product. So the inventory management, the IT solution. Nothing that I'm talking about here is really, advanced and difficult to do. It's very basic. When we were looking at the inventory management system, working at Merck, we're implementing SAP. We have a team of a couple thousand people deployed worldwide. It costs a lot of money, and we've been doing it for years now. We're looking at approximately a 3-month time period in Nepal. There's hardly any resources, really. How do we pick a solution, identify what we need, pick the solution, train the employees, and then ensure that it's sustainable once we leave? The stress was on. We were definitely concerned. So again, the scope was to select the appropriate inventory management software. We had a starting point. We had an MS Access database, which the hospital did not use. So we needed to map out the requirements. And then what we did was we identified 2 off-the-shelf systems. So again, from an internal process flow, we needed to map out what we were doing, what we needed. Inventory management. We recognized there was a need for, very basically, what do we have in our inventory? How do we deliver those products and account for delivery to our customers? How do we purchase new goods? When do we order more product? This should not be a gut feel. It should be a mathematical calculation. We should have max and min levels, reorder. Receive POs. The first day we were in T. Lockman, the stockroom guy's office, his desk was piled high with papers. Piled high, dust. It was crazy. And he said, what is all this? And he said, these are invoices that we need to pay. Some of them were 8 months old, 10 months old. And you're running a nonprofit. Every penny is critical. How do you operate that way? So it was important that the system was able to tell us, when POs were coming in, when we needed to pay them. And then finally, having all that wrapped up into a nice package that we could hand over to the finance group based in Nepal and the United States. So the system that we came up with was called Stock It Easy. And I have to give credit to my colleague, Nardi. We were Googling at night without electricity sometimes until we found something. We had a few days. I mean, it was like, okay, by the end of this week, we need to have a system. It needs to be tested. And then we need to roll out training the following week. So obviously, the benefits of our system was to improve control of our inventory. Do we have the essential drugs in-house? Where are they? The quantities. To understand what we use in each department. So, that Pareto chart was telling us, hey, here are the products that you're using in the quantities. And really to set us up for growth. We know that those outposts, we supply product not only to the hospital, but to the police and the external health posts. We needed to be able to expand that so the hospital could really do the best, have the best benefit in the community. Manual backup stock cards. Again, take yourself out of the comforts that we have here. If the electricity goes down, what do? Everything that we thought about, every solution that we had, we needed to keep in mind that we may not have the resources, the electricity to move forward. So while we had computers, we had internet, at any given day the internet would go off and on, the electricity would go off and on. So we knew we needed a simple inventory management system, and we needed a way to manage that inventory system if the electricity went off. So we used manual backup stock cards. It was simply a card stock hanging on each shelf with what the product was, the formula name, the code, and then how much was in inventory. And in addition to putting the information in the Stock It Easy system, we also had the storeroom associates manually put on the card. So at all times you had that backup. Something as simple as putting those stock cards together was a story in itself. Where do we get card stock? How do we print on the card stock? How do we hang the card stock off the shelves? I mean, things that are just so simple, you're in this environment, you would never think about. We ended up having to go back to Kathmandu specifically for some of these items. So training. The hospital staff, our pharmacist was about 20 years old. The hospital staff was very young. They had an elementary education level. When you're developing the training, we said, okay, we have this system, we love it, it's going to work, this is definitely going to work. Okay, we need to train folks that may not know how to use a computer. How do we do this? And the three of us, you're in this environment, we sort of fed off of each other's strengths. And Nardi was great with the IT solution, Philip was great with the details on the formula. I had experience training folks in the past, so when you're being challenged, those skills sort of surface up. So I sort of managed a lot of the training piece, and we put together a training module. Again, when I say put together a training module, it was about a day or 2-day process. You don't have a lot of time here. And we thought, okay, this is good. We have a little bit of classroom and online training. So the first day we go through our training, and all of our the employees that were there, we went through, they shake their head, yes, we understand, okay. The next day, or maybe it was that afternoon actually, we said, okay, everybody, get on your laptop and we want to see what you can do. Some of them didn't know how to use a mouse on their computer. Some of them, were able to use the computer before, but they weren't able to follow what we had taught them. And again, it's not forgetting, the environment that you're in, right? And realizing that, you're going to have to step back and start from square one. And, the three of us, we would sit in the dorm room at night and we're like, oh my gosh, today was a total waste of a day. Was it? You could debate that. We definitely learned something, and we were able to, gear our training the next day a little bit more specifically. Criticality of quality communication. So, I think this is something that we hear no matter what company you work in, especially larger companies like Merck. We need to communicate better. Nepal was no difference, and you're in this very small hospital. We were working in the store one day, and this is after we had the Stock It Easy running. We were still in the midst of training, and one of the doctors came in to the storeroom, and he said, he needed a specific asthma inhaler. And he was asking my colleague, Philip, he said, hey, I need this inhaler. And Philip, he knew all 300 products in the formula. He said, we don't have that product. We've never stocked that product. And Dr. Samporna said, well, that's crazy. I've been prescribing this since I started working here months ago. We came to realize that that product was never on the formulary. That patient was going to the pharmacy. The pharmacist would either give them something else or nothing at all. So we recognized that even though we made this accomplishment, we were so happy that we had this system in place, there was still a lot of work to do. There was still a lot of help that they needed, and really it was linking the doctors with the care that they were given with the work that we were doing as supply chain consultants. So what came from that is implementing standard processes, so SOPs. We introduced them to the hospital, standardized processes for all. I mean, we went from not only running the Stock It Easy system, but providing the maintenance and the general workers assistance with how they should mop the floor and clean the bathrooms. We wanted to assist in training new hires, cross-functional training. So a lot of the folks at the hospital expressed interest in learning a different part of the hospital. So we thought, here's a way that we can put a standard process together to help that process along. Again, logbooks to ensure tasks are being complete on time and by the appropriately trained employee. This was a labor of love. Explaining what a standard operating procedure is to folks in the United States can be sometimes a challenge if you've never been around them. Going into an environment like this, again, I provided training and then realized it was necessary to do a one-on-one with each patient, each hospital staff. And you know, the job, while it was a supply chain job, slowly through the process we realized there were a lot of other skills that we as supply chain professionals have that you may just take for granted. And I think one of the biggest things here that I learned was the mentoring that we were able to give the staff, the one-on-one lessons. It was humbling. It was an amazing experience to walk into this environment where, you know, the three of us show up and we were scared. We said, how are we going to convince this hospital? You know, we're going to identify things that need to change. And, you know, as we have all heard, you know, change is constant and nobody likes change. How are we going to go into this hospital and change quickly? And one of the biggest things was getting buy-in from the staff. And we realized that, without even realizing it, we realized halfway through our assignment that building that relationship, being genuine, having that trusting relationship with the hospital staff was critical in our success. So here, management consulting. Like I said, it was this eye-opening experience where the three of us were in our dorm room one night, and we said, yeah, we're doing the supply chain stuff, and it's easy. This IT solution is cake, you know, the training's okay. But what we found ourselves falling into is every single day, the three of us identified at least one or maybe more than one opportunities to improve the hospital. We even got to a point where we said we need to stop identifying improvements because we only have 6 weeks left here in Nepal. One of them was hiring the right employee for the right position. We were in the storeroom while we were doing training, conducting training. We recognized that this one guy in the storeroom, he did not know how to say his ABCs. He didn't know how to count chronologically. And you know, we had to make decisions on what to do with folks. We were fortunately able to take that employee and move him into a maintenance role and, you know, have somebody that would mentor him. We identified areas where we needed to hire employees. The first day we arrived at the hospital director met us, and he was this very eccentric dude, and he, you know, we show up, and he's from the US, but he's been living in Nepal, and I think he was doing some work in South Sudan and Libya, and I'm not going to use the exact words that he said, but he said, what the heck are you guys doing here? You guys are like just here from Big Pharma, and you're going to, you know, you're here on a 3-month vacation. I don't have time for you. And the three of us were, you know, we had our conversation in Kathmandu. We were thinking, what are we going to do? How are we going to be successful? And over time, we realized, you know, we had this passion of helping people. We wanted to do a good job. We saw the need, and we identified areas where we could be of assistance. By the end of our assignment, the hospital director came to us and he said, you know, what you guys accomplished would have taken me years. And it was just a moving experience. You're like, oh wow, like we were able to, you know, have this thought that what are we going to accomplish? And it turned into really, you know, changing the way the hospital was operating. Sustaining change. So a really big part was, okay, we're implementing, the three of us are here, this is great, we're making some progress. What happens when we leave? Is the hospital going to sustain the changes that we're making? And fortunately, over the course of the 3 months we were there, exactly in the middle, we planned to have a week of rest and traveling and vacation time. So we made sure that we implemented our Stock It Easy solution before we left. So that way we could give that 1 week sort of a test trial. How well can the hospital do without us? And they did great. I mean, maybe that's a testament to how well we were able to train them, but they really not surprised us, but they made us proud. When we left, we were able to use systems like Dropbox, Google Hangouts to, on a weekly basis, meet with the hospital and help them through some of the things that they had hiccups on. Again, something I forgot to mention was with the Stock It Easy system, every day the system would take what they had in inventory and they would download to an Excel sheet and put it on Dropbox. So we were able to sort of do a little spy on them through Dropbox and make sure that they were doing that and that they were ordering when they needed to order. Again, going back to Stock It Easy, the system was so cool. We needed to have a program that was so simple for the employees to use. We wanted a box that said, order new material. So when they would turn the system on, when they got in the morning, it would say, this is what you need to order this week. These are the bills you need to pay this week. Again, coming from an environment where folks don't necessarily have the experience technically, that's what we needed to do, and that's what would work. Keep it simple. So success measured. Stockouts reduced from 80 to approximately 3 occurrences per month. So when we arrived, the data we were able to collect, a stockout is the patient goes to the pharmacy and they're not getting what they need. Approximately 6 to 8 months after we left Nepal, we were able to collect this data to show that we went from 80 to 3. So I call that a pretty cool win. How do we accomplish our goals? So I think, this experience, it taught the 3 of us a lot, and it changed the way that we think about our careers and how we want to move forward in our careers. Again, building the strong relationships based on trust was critical. And you come back to the United States and you realize that sometimes we get stuck behind our computer. You're in your cube and you're not communicating. You're not interacting with people. I know within Merck, we'd use instant message for somebody that's sitting right next to us to ask them questions. Every day we were in the hospital, I woke up in the morning and I would eat my white rice, which I loved, and then I'd go into the pharmacy and I would meet with Krishna. And I would meet with him for about 45 minutes to an hour. And that conversation involved me observing what he was doing so that I could help him make improvements. It was learning about his life and appreciating the work that he was doing in the hospital, and it was mentoring him. And that happened very naturally, and it wasn't until I arrived home back into the United States where I had a call from one of the founding doctors at the hospital, and we were sort of debriefing about the experience. And he said, you have no idea what you did for this guy through the mentoring that you gave him. And similar to India, they have a caste system. So the folks in this district were the bottom of the caste system, very impoverished. For a wealthy Westerner come in and spend time, he said, you changed their lives. And again, you come back to the United States and you think, the interaction maybe that I have is not, what it should be with my colleagues here in the U.S. Cultural sensitivity. We needed to make changes. We needed to make them fast, but at the same time, we need to recognize that things may not be able to happen as quickly as we like. The training, it took us about double the amount of time that we wanted. So being aware of that cultural side of it, flexibility, again, I can't stress enough how, at the end of the day, you're sitting in a room with the mosquitoes jumping on the ceiling above your bed. There's dust all over your bed sheets because there's a dust storm that day. You're tired, but you keep in your mind what the goal is at the end of the day, and you see the people in the hospital every morning, and it completely changes your mindset. And those things that they're not the luxuries that you're used to in the United States, you sort of put them aside. You're like, well, that's not as important. Having a sense of humor, there were times where it was like, well, do we cry or do we just sort of shrug it off? Open to new experiences, and people are going to ask you, well, where do you see yourself 5 or 10 years from now? It's okay not to know. And I think for me, what this experience did was it challenged me in ways that I've never been challenged before, and it taught me that you want to be passionate about what you're doing. And I think anybody in this room, if you're not passionate and really enjoy what you're doing, is it worth it? And every day I woke up here with a smile on my face because I could see the changes that we were making as a team. It was truly a team effort. Nobody was trying to do better than the other person. The hospital, the staff, they wanted to learn from us. They didn't want us to just do everything and then leave. They understood we were there for a short amount of time. Again, be prepared to go over your comfort zone physically and mentally. Again, I can't stress that enough. I mean, and I think going out of your comfort zone, whether it's, you switch a job here in South Africa to something that you have no idea what you're doing, that's where you're going to learn, right? Once you get to that plateau, it's like, well, I feel comfortable here, but are you really challenging yourself? And again, keeping it simple. The next, I have a short video, and then we can go to a question and answer period. I put this video together really just to share with you, how, give you a flavor of what life was like there, and hopefully, maybe get you guys intrigued for some questions.
आज फेरि उनको यादले मलाई रुने बनायो आज फेरि उनको यादले मलाई रुने बनायो गुने गुन लाए पनि मलाई बैगुनी बनायो ओ गुने गुन लाए पनि मलाई बैगुनी बनायो आज फेरि उनको यादले मलाई रुने बनायो नजरको फुल बनी फुलिदिन्थ्यौ पहिले ओ नजरको फुल बनी फुलिदिन्थ्यौ पहिले सावनको झरी बनी आँखा भिजोइले सावनको झरी बनी आँखा भिजोइले आज फेरि उनको यादले मलाई रुने बनायो सपनीमा विपनीमा झल्को उनकै सधैँभरि ओ सपनीमा विपनीमा झल्को उनकै सधैँभरि बिर्सु भन्छु अतीतले घोचिरहन्छ घरी घरी बिर्सु भन्छु अतीतले घोचिरहन्छ घरी घरी आज फेरि उनको यादले मलाई रुने बनायो आज फेरि उनको यादले मलाई रुने बनायो गुने गुन लाए पनि मलाई बैगुनी बनायो लाए पनि मलाई बैगुनी बनायो आज फेरि उनको यादले मलाई रुने बनायो
Okay, so the one last comment that I have is, when I came back from this experience and you go through this transition. You come back to the U.S. and you start thinking a little bit differently, like what just happened to me? And I had presented in Las Vegas last October, and I've even changed since October to now. And I've been going around, and my goal right now is to sort of just try to inspire and explain to folks similar to this audience, that we have skills and capabilities to help people. And we had a major success with this hospital. It was a great feeling. And I tell people, if I can be selfish, what I got out of this was so much more than I probably gave them. And I encourage folks in this room, if this is something that interests you, explore opportunities. Maybe it's you can't take 3 months off of work or even a week, but look to local organizations around where you live that, right now since I returned, I'm living in New York City, and I started working with a food pantry that supplies food to homeless folks. And I was there last November, and I recognized their storeroom was a complete mess. And I was like, all right, I know what I can do here. I can help you guys. And so I encourage you guys, and it's okay, be a bit selfish about it. Do things like that so that you can learn a lot about yourself, learn what's important, and really, I'll leave you at that. So I'll open up to questions, and if anybody has questions.